Okay, so we are in Dr. Carmen Pinto's session 1B. And I'll just say that we met Dr. Pinto through working with NAMI Heartland, and NAMI Heartland is part of the Elizabethtown area. So we first learned about Dr. Pinto working at Communicare, which is one of the community mental health centers there. So Dr. Pinto is a licensed psychiatrist with Communicare and some other areas surrounding, like U of L and so forth. And he's going to present to us today on long-acting injectables. We're super excited to have this topic because I've been at NAMI 5.5 years, and schizophrenia seems to be a really big mental health diagnosis in the state of Kentucky. Like normally when we get a lot of calls, people do have bipolar and depression, but we get so many calls about someone's son or daughter or niece or nephew that has schizophrenia. So this cutting edge medicine is great to learn about. And I know some people are using it already. And so Dr. Pinto will be able to tell us more about it and his successes and so forth with it. So without further ado, we're going to introduce or present Dr. Carmen Pinto. Let me check, make sure.
Hello, can you hear me?
Okay, now we can hear you, Dr. Pinto.
All right, I switched microphones. All right, well, good morning. Thank you for bearing with us today as we talk about injections, long-acting injections of antipsychotics as a future direction of treatment for both schizophrenia and bipolar disorder. I think this is quite timely when you think about what just happened with COVID, where there was a big discussion in this country about injections, and people were like, hey, be patriotic, take the jab, all this kind of stuff. And there was all these discussions, and I really think it was actually quite beneficial to focus on the idea of injectable treatment for conditions. And what's amazing is that we've had for almost 10 or 20 years the availability of long-acting injectable antipsychotics of the newer generation of antipsychotics, what we call the atypical antipsychotics, or the second generation. And these are really the preferred choice, the second generation of antipsychotics. And it's unfortunate that in the United States, only about 10% of the people who suffer from schizophrenia, and even less who suffer from bipolar disorder, are treated with injectable antipsychotics. And in my opinion, they're by far the preferred way of treatment. So I'm a psychiatrist who's done community mental health for over 30 years. I did general medicine for 5 years when the Navy put me through school. I'm an assistant clinical professor at the University of Louisville. I'm also a promotional speaker.
What's this over here? Is these in these volume
contractor
no.
by these companies to educate other physicians and psychiatrists about the use of these medications and the practical logistics of how to actually
on the side thing.
So bipolar disorder and schizophrenia are really devastating illnesses. These are illnesses that attack people early in their lives. And unfortunately, they rob people of some of the experiences and opportunities in life that other people
but what's the SD stand for, you know?
And there's actually a concept called social drift that we're going to explain in a slide in a minute. It talks about the sinking functioning of people who have these disorders when they're actively symptomatic and untreated or poorly treated. So this slide actually is a representation of the impact of schizophrenia as a model illness on an individual. And the concept is that it affects all realms of a person's life.
So tell me where on the keyboard, even though you can't make it in
their ability to take care of themselves, their ability for interpersonal relationships,
somebody to mute their
and social
screen,
activities.
we can't hear.
And with schizophrenia, what we see is
a
condition where we know that there is dysregulation of multiple
you have to
neurotransmitter
whisper into
systems.
it, or how do you do that? For you
And it turns out
how do you
that
turn up the volume?
dopamine is the neurotransmitter we know the most about and have the most ability.
Excuse me, we
modulate.
can't hear. Somebody
that
needs to mute their
Dopamine levels
screen.
can be different in different areas of the brain. In some areas of the brain, there may be too much dopamine, and we believe that what you'll see then is what we call the positive symptoms. Positive symptoms are things that are present that shouldn't be there. And so most of the time, these would be hallucinations and delusions. Hallucinations can be hearing something. That's by far the most common. Seeing something, it can be tasting something, smelling something, or feeling something that is not there. And that's where the concept of reality testing comes in. How do you know if something's really real or not? If you're hearing voices in your head that are, saying things and talking to you, or you think you hear something coming out of the radio or the TV is talking specifically to you, one of the things we try to do is we work with people to help them try to understand what is a way that I can figure out if something is real or not. And we call that reality testing. So the point we would try to do is we would try to medicate someone to try to lower dopamine in that particular area of the brain and hopefully improve those symptoms of hallucinations and delusions. We see negative symptoms. Negative symptoms are thought to be biologically connected to areas of the brain that are under active. They don't have enough, for example, dopaminergic activity. And so negative things are things that should be there that aren't. And so some examples would be emotional stability, motivation, joy. Cognitive symptoms represent kind of the overall functioning of what we expect a brain to do. Things like attention, memory, executive functioning is talking about abstract thinking and decision making, and those become impaired. Cognitive symptoms is something that we take for granted. And this is interesting because as teachers, we realize most events are complex chains of decisions and actions. So if I said to my son, hey, go fill the car up with gas. Well, that's a very complicated situation with a lot of chains that have to be done. Like he would have to think, okay, I have to find the keys for the car, have to start the car up, I have to drive it to the gas station, I have to have money or a credit card, I have to know how to activate the gas pump and open the gas cap on the car, I have to put the pump in there, I have to turn it on, let it fill up, shut it off, put it back, put the cap back on. My point is, this is a very complicated process. And I remember early in my career working with a gentleman in Litchfield, Kentucky, and his wife. This was a young man. He was about 22 years old, who was just starting to have the onset of schizophrenia. He'd been released from Central State Hospital. He was on medications, and the medications tend to help the positive symptoms much quicker than they help negative symptoms or cognitive symptoms. And so he was no longer psychotic, and he was unable to work. And I said, it's really important to keep yourself busy and that kind of stuff. And so he went home and he tried to mow the yard. And I remember his wife talking to me as she looked out the window over the sink from the kitchen. And she said he was just sitting there looking at the lawnmower with the gas can sitting next to him. And he couldn't remember or think through the process of how you actually fill the mower with gas to mow the yard. And I remember how tearful she was because she had a young child and she was pregnant with another, and she was wondering how she was going to make it with this man who was suffering from schizophrenia, who couldn't even think correctly to be able to put gas in a lawnmower. We also see an effect on mood symptoms with these illnesses, and that would be things like agitation, anger control, anxiety, depression. So this chart is very, very important. I hope you can see my laser pointer. Over here on this scales, we have functioning, and functioning is arbitrarily divided up into 100%, which would be full functioning, and 0 would be no functioning. And what you see is a course of illness here in this blue line. The beginning here is prodrome. That means before the condition starts. And down at the bottom, we have age in years. And so you can look straight down from this first arrow, and you can see age in years for onset of schizophrenia is usually around 18 to 20 years old. And what happens is people will have their first psychotic break, which is demonstrated by this dip in the blue line, and their functioning is severely affected. It goes from full functioning to maybe around 60%. And then hopefully the person will get appropriate treatment, usually in hospitalization, and they will get better. And when they get better, their functioning improves, but you can see their functioning never gets back to the original baseline. Now it's about 85% maybe. And then over time, the person will get sick again. Usually they get sick again because they are maybe having a difficult time accepting that they have a chronic mental illness, and they decide after they're better, they don't want to take their medication. Maybe they're using drugs and alcohol, and maybe they're doing both. And those tend to enhance the chance that people are going to relapse. And so we see a relapse, and this time you can see that the patient is sick longer. It takes longer for the medication to work. When the medication does finally work, you can see that the baseline is sunk again now. And this period goes over and over and over again until we get 10, 15 years out, multiple relapses, multiple hospitalizations, and we see that the patient's functioning has deteriorated greatly, which would significantly increase the risk for homelessness, hospitalization, incarceration, utilization of emergency services, and really just a struggle in life. And then finally, I've got a purple arrow over here, and that purple arrow represents the average age that people are first started on long-acting injectable antipsychotics, and it's around 37. So that means about 17 years, almost 2 decades after somebody's been sick. We do the same thing over and over again, even though it's not as effective as we wish it would. And that's really the question. It's really the question about this talk today. Why do we wait 17 years and let people continue to suffer and do the same thing over and over again that doesn't seem to be effective? And this is an example. Back here, you can see at the bottom, these are structural CT scans. And what you're seeing, the black on these represents empty matter, empty space that is filled with fluid. And you can see that with every episode, there's more and more space that develops, meaning that there's more and more brain loss. This is actually a CT scan of the brain, and you can see the healthy brain on the right, and then you can see all this dark area on the schizophrenic brain. This is probably after a decade or so. You can see that they've had all this brain loss. You can see that the outside has started to shrivel, kind of looks like a walnut shriveling up here, and this. And that's the reason the baseline continues to shrink, because as you lose brain matter, you lose the potential to return to your original baseline functioning. And so why do we let people fall? Why do we let them sink when we actually have treatments that are effective? So the traditional treatments are pills, and that's really the issue. It's not the type of pill, it's that it's a pill. We have first generation antipsychotics, which have been available for 70 years. And these are things like Haldol and Thorazine, and they were very, very effective medicines, but they were very aggressive in their ability to affect the dopamine system in the brain, and they had a significant amount of side effects. About 30 years ago, we had the development of what we called second generation antipsychotics, SGAs, or some people call them atypical antipsychotics. And they were atypical because they worked a little bit differently than the first generation antipsychotics. There was a more moderate effect on these neurotransmitter systems, and it was more balanced. It tried to actually release dopamine in areas where they would be low and decrease it in areas that was high. So it was more balanced in the first generation that could knock down the high areas, but they didn't do very much for the low areas. And so still all these medications are approved and effective. Unfortunately, as pills, they all have to be taken daily. Now, the second generations and the first generations are available in long-acting injections, and these injections can be taken every couple of weeks to the average is about once a month. We actually have a 2-month injection for some of the medications. We have a 3-month injection, and we now, in this last year, we have developed a 6-month injection. Think about that. These injections are meant as monotherapy. You don't need to use pills along with them. And so somebody who suffers from schizophrenia could take an injection twice a year and totally treat their schizophrenia with what I think is a side effect profile that is, if not as good as the pills, maybe better. And so this would really be what I think is the preferred method of treatment. And when I talk to patients, I really describe it as the Cadillac of treatments. This is amazing. Now, to get to a 3-month or a 6-month injection, you have to start with a monthly injection for a few months. And before you ever take a long-acting injection, you have to try the pills for a couple of days just to make sure you're not allergic to the medicine before you would take a long-acting injection. So we know, we've got plenty of data, and I'll show you this in a second, that the most common reasons people relapse and get sick and rehospitalized with schizophrenia or bipolar disorder is that they do not take their oral medications. As a matter of fact, if you look at people in general, they only take their medications 70% of the time, according to Consumer Reports. And so we have a human condition, which is not to actually take our medicine. That's actually the normal, not the exception. But we continue to pretend that everyone is going to take their medications as they should, and then we're surprised when they get sick. And one of the major factors is because they haven't been taking their oral medication correctly. The second most common reason people with schizophrenia and bipolar disorder relapse is substance use. We're talking about alcohol, marijuana, methamphetamine, pain pills, you name it, over-the-counter stimulants like Red Bull and all this kind of stuff. It's unfortunate because these medicines actually create in the brain the same biological condition that we see when people get sick. So, the metaphor I use with my patients is you're swimming in the wrong direction. When you use drugs and alcohol, you're swimming your brain in the wrong direction. It should be going in the direction of taking their medicine. And so if the most common reasons that people don't do well is because they don't take their oral medications correctly and because they're using substances and maybe both, then when people come to me after they've been sick for 10, 15 years, which is how they get to our program right now is a special program for people who have not responded well to standard treatments. I say to them, you need to take a shot and pee in a cup. And they always say, I don't want to take a shot. I don't want to pee in a cup. And then I explain to them, I don't see how things are going to get better. And one of the things I try to do is initially I say to them, hey, what is it you want from your mental health treatment? Why are you here? And they say, I want to get a job. I want to live on my own. I want to get my driver's license, my kids back. I want to get off probation or parole. And I say, well, I think you maybe could do that. There's a pretty good chance. I'd say there's a 2 out of 3 chance that can happen for you. And it's going to start with you taking a shot and peeing in a cup. Because if I can't make sure that I have your medicine in you at a consistent and regular way, and that you don't have things in your system you shouldn't have in you that are working against what we're trying to do, it's going to be very hard for me to help you. The third most common reason people get sick is stress. And this makes sense. Stress is like gas on fire to mental illness. And so after we kind of get people stabilized on injections and try to monitor them for substance abuse and help them understand the consequences of substance abuse and the value of substance abuse treatment, striving for recovery and sobriety and abstinence. Then we talk about stress and managing stress and trying to help give them the resources that they need to deal with that. The fourth most common reason people get sick is the course of the illness itself. If you remember that graph I showed you where every time people get sick, they sink a little bit and their brain shrinks. Eventually that becomes a pattern that sometimes is hard to, what you see is people cycle on an annual basis or a couple of times a year. And we might be able to shorten those lengths of stay and maybe decrease how many they get. But the longer somebody's been sick, the more damage their brain takes, the more deteriorated it becomes. And the question is then, why aren't we more aggressive early in the illness? Why don't we, within the first couple of years of diagnosis, start thinking about a long-acting injection? As a matter of fact, what I would suggest, and what I believe, is you should try a course of oral antipsychotics when you first get ill. And if you're successful, God bless you and go your way. If the first set of oral antipsychotics is not successful, people relapse, say, within a year, or they're just not able to take the medications correctly, or they have some other trouble with it, then I would suggest a trial of a second type of oral antipsychotics. And we have 2 basic mechanism of actions in these new atypicals. One's called an antagonist, one's called a partial agonist. You don't need to remember all that detail, but you just need to know there's a couple of choices. It's not just Coke and Pepsi, you got Coke and 7-Up. And so I tell them, try the other one. And after a certain amount of time, if they do good, then they go on their way. If they have trouble with the second one and you've tried both mechanisms, then I think you need to try the injection. So maybe we're 2 years into the illness now, and I would suggest, hey, try the injection with one of them, the partial agonist or the antagonist. If after 6 months to a year you're still not doing well, then I would suggest trying the other mechanism, switching over to the other one. And then finally, after that, if you're still not doing well, there's a final medicine called Clozaril. And Clozaril is a pill, not an injection, and it has a fair amount of side effects. You have to do blood monitoring and things because it can cause some pretty severe side effects, but it also tends to be the most effective medication we have. And again, I would lay this out as Cadillac treatment. This is the best treatment, and it's available today. You have 2 courses of oral antipsychotics. If you fail those, move on to the long-acting injectable antipsychotics. And if you fail those, then move on to Clozaril. Like I say, with the long-acting injectables, I've got some fantastic news that I would like to share. So here's the information about how often people don't take their medications. This is a study that's about 20 years old. And we knew that this is done by the NIMH, so it was a government-sponsored study. It had about 1,500 people with schizophrenia in it and went on for 18 months. And what they found was 3/4 of the people did not take their medication as they should. So again, it's not the exception, it's the rule that people are not going to take their pills. And then when they tested or monitored for substance abuse, 2/3 were using substances, and half of those were really, really, really dependent, and they by far had the worst outcomes. So again, this is kind of evidence, and we've got many data like this, that generally people are not going to take their pills as they should, and they're going to have trouble with substance abuse. So again, let's make it simple. Take a shot and pee in a cup if you really want your best option to try to get optimal outcome from your chronic mental illness like schizophrenia or bipolar disorder. Here's some studies that really, these just blow me away. Long-acting atypical antipsychotics compared to any oral antipsychotic. Now, they didn't do any because there's dozens of them, but they did the most popular ones, like the 9 or 11 most popular antipsychotics, both first generation and second generation. And actually, they even used the pill form of what's in these long-acting injections. And compared to any pills, given any way you want to do it, the long-acting injectable antipsychotics had better outcomes. 21% reduced risk of hospitalization in the first 30 days after being released from the hospital if you were on a shot versus a pill. 21% reduction. If I said to you today, hey, I'm going to give you a 21% raise, I bet you'd be jumping out of that chair. 176 days on average delay until relapse in a 2-year study. That's almost 6 months longer for the people taking the shot to get sick than the people taking the pills. And remember, every time somebody gets sick, they lose brain matter. 6 months longer delay if you're on the shot versus the pill over 2 years. Same study over 2 years, 31% less psychiatric hospitalization on the shot versus pill. And look at this, 28% less arrest and incarceration. Now, here's the one that I think is amazing. This is actually a very new study. They looked at people taking a long-acting injection over the course of 52 weeks, because the longer you're on the medicine, remember I talked about how the positive symptoms get better pretty quickly. Those negative symptoms don't. The cognition problems, the negative symptoms, the things that should be there that aren't, they take longer to get better. And you have to, every time you get sick, you go back to square one. So you have to stay, well for a long time, and 52 weeks is a pretty good chunk of time for people to actually improve those negative and cognitive symptoms. And this study actually showed that 58% of people who were on a long-acting injectable antipsychotic for 52 weeks were symptom-free, according to the criteria they used. Symptom-free after 52 weeks of long-acting injectable antipsychotic for their schizophrenia. And we only have 10% of the people with schizophrenia in this country right now on these injections. So you ask me, what's going on? Because I ask myself that all the time. Medication only works when it's taken. We know it's human nature that people are not going to take their medication like they should. So atypical long-acting injectable antipsychotics really are the preferred treatment. And some people say, well, who's appropriate? Well, really all people are appropriate, but especially people that don't have a really healthy support system, especially people who are disorganized in their life and are maybe living on the street, especially people whose brains aren't working the way they should, especially people who have taken drugs and alcohol, especially people who maybe are high risk for suicide because they're despondent and frustrated with dealing with mental illness. These are all folks who could be on long-acting injectable antipsychotics. What do these injections not do? They don't fix drug and alcohol problems. And honestly, in my experience, the drug and alcohol problems are harder than getting people to take the injections. I'm actually very good at getting people to take injections because you just talk to them in a curious, caring, passionate, and genuine way. Hey, I would really like to help you. I really think if you were one of my family members, this is what I'd want for you. Why don't you give it a try? If you don't like it, you can stop. You know, hey, I mean, we've done all sorts of stuff. We've taken people out to eat. I had one person said, you know, if you get me an ice cream, I'll take the shot. Hey, here you go. You know, for a couple of bucks of ice cream, person took an injection that's going to last a month. And maybe not up in the hospital or the emergency room and save that cost to us as society. Maybe not end up in jail or homeless. Maybe not have their mom worry. One of the things that's super interesting about these injections, we're talking about what they can't do, but I think one of the things they do quite well is they tend to reduce conflict in family situations. When we go in and people are living with their adult caregivers, the major source of conflict is over, did you take your medicine? And it makes sense. The person who is acting as the caregiver is concerned. They've seen this person get sick. It's caused a lot of difficult, it's tragic for them to witness and to see, and very stressful. And so they know if the person takes their medication, they're likely to do better. And so they're kind of constantly, hey, did you take your medicine today? Did you take your medicine today? And that can become annoying to the person who has the mental illness. And they're like, hey, leave me alone. I'm a grown person. And so we see all this conflict. And when we go in and put people on injections, we say, hey, don't talk about medicines anymore. The shot is meant to be monotherapy. It's meant to do it all. We don't need pills, at least for their schizophrenia. Maybe they need them for blood pressure or something like that. But we don't need the pills anymore for schizophrenia. So let's not argue about it anymore. And we see the conflict go down. I showed you the data, how there was longer times between hospitalizations. One of the other things that has been my experience is the hospitalizations are shorter if somebody does go to the hospital, if they have the injection on board. But the injections don't fix personality problems. I mean, if somebody's got a temperament or something, that, I mean, it's not going to change that. It doesn't change how people think in the sense of who they are and how they think about things. It doesn't fix relational problems, and it doesn't fix social problems. So we really think the second generation drugs are the best. And so we would suggest a long-acting atypical second generation. But if those don't work, we would definitely try first generation. We tend to try to get people on the longest dosing period possible. So right now we've moved a lot of people to 2-month injections or 3-month injections. The 6-month injection is brand new, so it's a little bit hard to get. Sometimes insurance companies make us jump a lot of hoops, but that would be our ultimate goal. And why? Why would we want to use the longest dosing period? Because that gives the person who suffers from mental illness the chance to be just like anybody else their age. They don't have to take a pill once a day to remind themselves that they're mentally ill. They could take an injection twice a year, possibly, and, you know, then go about their business. That's what I want. I tell people my goal for you is to be able to do anything else anybody else your age can do. You know, it's your choice to do what you want to do. It's my job to try to help you get there. And I don't pull punches. Take a shot, pee in the cup. And like I said, most people are not jumping up and down, woohoo, I'm going to take a shot and pee in a cup. They always say no. And, you know, why wouldn't they? Who would want to take a shot if they don't have to? Who'd want to have to pee in a cup? I mean, it's about trying to explain to people what the advantages and disadvantages are and how it's in line with what their goals are. And again, Europe, they use 50% or more of their patients they give injections, but they have a unified health system. They have a health system that says, hey, not only do I have to pay for the medicine, even if it's expensive, I have to pay for the ER visit. I have to pay for the hospitalization. You know, as a society, we pay for jail. And if you can reduce that, like I showed you, why wouldn't you maybe pay a little more for the injection than the pills. Barriers to using them, really it's the person themselves, prescribers, healthcare system, and payer systems. With the client, it's always about anxiety and fear. They don't know what to expect. It's a little bit scarier to say, hey, somebody's going to give me a shot than me taking a pill. And so anything we can do to help reduce fear and anxiety, usually through education, caring. I always bring in the person who's going to give the injection. I've given hundreds of these injections myself, but now I have a nurse. And the questions always are the same. Is it going to hurt? Who's going to give it to me? You know, do I have to get naked? What part of my body are they going to do it? That kind of thing. And, you know, I bring in the person who's does the injections, and I say, hey, this is Teresa. She's my injection nurse. Hey, Teresa, is it going to hurt? And we tell the truth. You always want to be honest with people. This injection, and that's the difference between one of the big differences between the first generation and the second generation, these atypicals, is the atypicals are water-based injections. The first generation were oil-based, and getting an injection with an oil-based medicine, not too comfortable. The second generation, which are water-based, we use the same size needle that you would use for a flu shot or a COVID shot. So they're about the same discomfort level as a flu shot or a COVID shot. People have experienced that and they know what to expect, and it's not as big a deal. So anything we can do to reduce anxiety and fear, answer questions, educate patients, makes them more likely to give the injection a try. Prescribers, I think, are one of the bigger barriers. And it's interesting because I educate prescribers all around this country. And when I go talk to them, they say, oh, hey, I understand everything you're saying, doc. You know, I should use more, and I would, but it takes 10, 15, 20 minutes, maybe a couple sessions in a row to talk somebody into taking a shot. And I just don't have that kind of time. I've got this much time for my visit. And if they're willing to take the pill, here you go. And so the prescribers struggle because the way the system is set up, productivity standards, things like that the easiest thing to do is actually just continue the pills as they are. And that's why we see this pattern where people take pills for 17 years before they ever get offered an injection. And so here's the whole point of my talk today. Here's the reason I'm excited to be here is this. I think if people who suffer from mental illness and their loved ones and their support systems go into the office and say to the prescriber, hey, I want this 2-month injection. I want this 3-month injection. And they're appropriate. There's no reason the prescriber won't write it right then. I really think this is the way to go. This is the way we get more than 10% of our people suffering from schizophrenia and bipolar on long-acting injections, is they have to ask for it. They have to go and say, I want to be on the injection. And I'm pretty sure the prescribers would write it. And that would get through the first 2 barriers. The third barrier is healthcare systems. And what that means is they need somebody to do the injections, you know, so they need injection nurses and that kind of stuff. Although that's becoming more and more available as pharmacies and other people are willing to do these services. And the last one is payer system, insurance companies. And this is a system in our country that is a little bit fragmented. We have everybody looking out for themselves. The hospitals say, hey, these are expensive, these injections, so it's better for us to not have them on our formulary. It saves us money, and they can get them when they get out. And then you have other places where they may not be available on the formulary because people are trying to keep their formulary costs down, but the people who are keeping their formulary costs down don't pay the cost of the emergency room or hospitalization or incarceration, or have to deal with the suffering of the folks who are homeless and maybe struggling with their illness because they're not taking their pills correctly. And so we really have to look at all these barriers. But today, my message is, if you know somebody, a loved one or a person who has got schizophrenia or bipolar and they're not on an injection, try to educate them and encourage them to go ask for the injection. The injection is a personal choice. And again, like I said, it's over a decade before people get put on injections after multiple pill failures. And my whole point of this talk today is that if people would ask earlier, they could save maybe a decade, get on them a decade earlier after the course we talked about, 2 fair courses of oral antipsychotics, and then move on to the injections. And if they did that, think of the brain that they could preserve. Think of the functioning they could preserve. Think of the more opportunities that would be available to them because they would be at a better functioning level. Think of the loved ones that would benefit from this person being more consistent and stable with their condition. I mean, it's just, it's tragic to think we've got it available now for almost 20 years and we're only using it in 10% of the folks. The approach for prescribers is basically talking to folks about injections, like I said, encouraging them. I've got a tie on right now. You can't see me, but it's got syringes on it. I've got a little syringe lapel pin. I bring it up all the time. If a patient's not on the injection, I'm like, hey, you really ought to give it a try. I'll tell you what's interesting is I've got some patients now who have been on injections for years, and they're doing very, very well. They're doing so well, they come in and they say, am I really sick? Do I really have schizophrenia? Do I really have bipolar? Don't you think maybe I could come off the medicine because I don't really think I'm sick? I mean, that's a great problem to have when your success is so good that the patient can't even remember what it was like to be mentally ill. And I have that happen. And I beg people, I please don't go off the injection. The reason you're well isn't because these aren't curative treatments, they're palliative treatments. They make the condition better, but they do not reverse the neurotransmitter dysregulations that people with schizophrenia and bipolar are born with. These are lifelong illnesses, but if you can get somebody symptom-free like we showed, I mean, my gosh, I'll take that problem anytime, getting people all the way well that they don't even know if they're mentally ill. So the support system, be positive, be calm, be patient. We have a lot of people that push hard and it creates conflict, and conflict doesn't help. Be caring, be curious, and acknowledge it's a person's choice. And this is a process that people can move through. I always tell my students, you never know when a patient is going to say yes. So you keep being caring and curious. What's holding you back? What do you think is the worst thing that could happen if you took the shot? You want to ask those questions. You want to explore that. I have a lot of prescribers say, hey, I asked them, do you want to take a shot? They said no, and that's where they stopped. And that's part of the problem. If I said to you, hey, do you want to take insulin for your diabetes? And you said no. And I was like, okay, well, I guess that's it then. I would be every time, hey, you really need this insulin. It's super important. Look at the impact it can do. Look at how we approached COVID and the injections with COVID. We said, this is important for you as an individual. It's important for us as a community. Come on, let's give it a try. It's like a little bee sting. It's a little prick. It's not a big deal to take the injection. So anyway, I think it's important for patients to understand that they don't have to be scientists and understand everything. All they need to know is that these injections are available and these medications are available in long-acting injections. There's a newer generation called the atypicals. Those are the ones that I would suggest to start with. And that they're available in a variety of dosing lengths, from a month up to 6 months. And again, you can't start right on the 3 month or the 6 months. You start on a 1 month injection for about 3 or 4 months, and then you can move on if you do well. But that's fantastic. And in our own program, when somebody moves on to a 3 or 6 month injection, we actually have a little certificate we give them. And, it's a big accomplishment. We really get excited for people who are engaged in their treatment and really making what we think are healthy choices to try to stay better and deal with their illness. So it's a personal journey to recover. Nobody walks alone, and there's always hope. And I'll finish with saying, if people in their support systems ask for long-acting and atypical antipsychotics from their prescriber, the process to get somebody on one of these and potentially, but maybe move it up by a decade, could decrease hospitalization, incarceration, homelessness, and possibly preserving brain mass, which would lead to higher functioning and social abilities, and the opportunity to do the things that other people their age do. So with that, I'm going to stop and see if there's any thoughts and questions. I really appreciate your attention today.
Okay. Does anyone have any questions? We still see the PowerPoint.
Melanie, I'm not seeing the chat, so if there's something there, you could maybe read it to me.
Okay, let's see. Let's see. No one has put anything in the chat.
Melanie, I'm sorry. I do have a question that was sent to me directly from Brenda and Jim Benson. Oh, looks like she just sent it in the chat again. Sorry, you can take it over.
Okay, it says, will the slides be available to download? Or Dr. Pinto, can you email that to me and then I can share it with those people who attended the class today?
Yeah, I've already emailed it to you.
You've emailed it to me. Okay, great. Great. Yes. So I can send that to everybody who attended the class today. Yeah. Is there a way where we can see you, like I can't see the class here. Let's see. I still see the PowerPoint.
You'll have to, Doctor, you'll have to, at the bottom, select stop share.
Okay, now I can see, okay, now I can see the rest of the class. Okay. There we are. Okay, Ben, Jim has a question, I think. Or either a comment. Can you take your off of mute? Or were you just waving?
Oh, I'm off mute, I think.
Oh, he was just waving. I was talking about Jim Benson with NAMI Murray. He was just waving so we could see each other. Hey, I think there's Tracy.
Yeah. Can I ask? Hi. Is it easy in Lexington, Kentucky to get this Clozaril? It seems like families I've talked to said that a lot of the providers aren't educated on it or are reluctant to prescribe Clozaril. Yeah,
Clozaril really is an interesting medication. It's actually been available since 1990. It was actually originally banned in the United States because there's a 1% chance of mortality due to decreased white blood cells. And so it was really families who had people that weren't responding to standard medications that really petitioned the FDA to get Clozaril available in the United States. And when Clozaril was made available, there was a very strict monitoring schedule. You have to do blood tests once a week, and you have to have a lot of stuff done to do it. So that system is a little bit difficult, and so it's not necessarily available everywhere, and you have to be registered to use it and things like that. So in Lexington, the University of Lexington Psychiatry Department, there should be probably somebody there who's capable and registered to use Clozaril, but you won't find it, like, for example, in every community mental health center. A lot of the prescribers we have now are not registered to use Clozaril, so that may be part of the issue.
Mm-hmm. And to be registered, do they have to take a class and everything?
They do. There's some things you have to do. You have to get registered. You know, like Suboxone is similar. You have to get registered if you're going to use Suboxone and things like that. So the government has certain standards and things that you have to do.
Okay, thank you.
Okay, let's see. From Leslie, it says, what are the short and long, let me go back to the chat. What are the short and long term side effects of the LAI?
So interestingly, the side effects are exactly the same as what the oral medicine would be for that shot. But how injections work versus pills, when you take a pill, what happens is you get a very high level in about 30 to 90 minutes. We call that the peak. And then the medication will be metabolized or eliminated and slowly fall. And when it gets down to the bottom, what we call the trough, or the valley, peaks and valleys, if you want to say that, you take another pill the next day and it goes back up again, and then it drops slowly, and you take another pill, it goes up and it drops slowly. So you see this sawtooth pattern of blood levels. Now, what's interesting to understand is that the medication has to be effective at the valley. Even at the lowest amount in that 24-hour period, the medicine has to be effective. So if the medicine is effective at the lowest point, everything above the lowest point is extra. It's just there to keep the medicine in your system by taking a pill. And it's higher serum levels is correlated with higher side effects. And so think about it. Most people take their medicine at night, so they try to sleep through the fogginess and the fatigue and everything else that they might get from these medicines short term. And then it drops and they take another one. When you take a shot, the day-to-day change in blood levels is almost nothing. So the medicine is much more level in your system, and you don't have these high peaks and drops every day that you would get with a pill. And the lower levels, in my opinion, actually lead to lower side effects. So the side effects are exactly the same as they would be with the pills, but I actually think they're lower. The side effect is more is the one that says, ouch. Most of these injections, when they rate the discomfort level, they rate it from 0 to 100, 100 being the worst pain, 0 being none, and they rate around a 5 or a 7 on the first injection. By the time they get the third and fourth injection, it's down to about 3 or 4. So that's less than a bee sting. Again, they're exactly the same size needle and water-based injections. So the discomfort is the same as a flu shot or a COVID shot.
I have a question. I know you were showing a picture of the brain, the normal and a person with schizophrenia. So once you start to take the medicine, I guess my question is does it like stop all of that growth? So if it was kind of like this big, then, and you start taking the medicine, will it stop it from increasing?
So here's some bad news for everybody. All our brains are shrinking. The older you get, you are constantly, most people in America today are losing brain mass at about 1% per year. And people with schizophrenia are losing 1% per year also, as well as 1% every time they get sick. So you can see that they would be losing at a more rapid rate. Now, brain can be lost very quickly. It doesn't take much to damage brain and kill it and lose it. It takes a lot to grow it back. We used to not think brain could grow back, but it can actually grow back in certain areas and under certain conditions. What would those conditions be? They would be stopping whatever it is that's, increasing the speed of the brain loss. So that would be keeping the person not having relapses and symptom-free, stopping the drugs and alcohol, dealing with stress, all the kind of stuff we want to do. And then there's actually data out there right now about what we could all do to grow our brains. And so exercise is excellent. And so you're talking about not an unreasonable amount of exercise. I think like 90 minutes, 3 times a week actually has been shown to slow brain loss. Mental exercise is also important. So not just being passive, sitting in front of a TV or sitting on a couch, but playing cards or doing Sudoku or whatever. And you want to do a variety of mental things to use different parts of your brain. You have to exercise all parts of your brain. So, one of the things I've suggested a long time ago to our team, one of the best things they can do for our clients is to say, hey, let's go for a walk around the block when it's appropriate. And while we're walking, let's do brain teasers. And that simple could actually help all of us slow down brain loss and maybe actually regrow brain. But like I said, the regrowing brain is a very slow process. That's why we don't see some of this improvement until we have these year-long studies of people being stable. And like I said, every time they get sick, they go back to square one. And so it really is sad for us to see. I mean, I'll tell you a couple of cases. I had a young lady I met, and I treated her very successfully for schizophrenia for years. And she was one of these people that got to the point that wondered, am I really schizophrenic? Do I really need to take my medication? And so she came in, this was with pills, actually. She was a very reliable pill taker. And she actually came in, took the prescription for the pills. Her family was going on vacation to Las Vegas. She went to Las Vegas. She decided not to take the pills to test to see whether she was mentally ill or not. She did some stuff in Las Vegas she probably shouldn't have done, but it didn't stay in Las Vegas. It followed her home. She relapsed and got sick, and it was very difficult. I never saw her return to the baseline she had been. She got better, but she didn't get as well as she had been, and it took, I think, 1.5 years for her to get leveled out again. And so that was just broke my heart. And after she was well, she sat and talked to me, and she said, it was interesting. I remember that day you gave me the prescription, and I decided I was not going to take it, and I wasn't going to tell you or my family because, basically she felt, hey, this is my choice. And again, the thing for me is it might be your choice, but why not talk with me about it? It's your choice to buy a car too, but wouldn't you want the best information you could get from the car dealers and Consumer Reports and everybody else before you make your decision? That's my point, that, hey, I can't make you do anything you don't want to do. The choice is up to you, but I want to give you all the information I can give you. So when you make that choice, you have the information, the the pluses and the minuses that you weigh your decision on.
All right. Well, we have like 2 minutes to get into our our other rooms, but I will say that Mary Otter said that this is very informative. Her son received some sort of shot, probably at LAI, where he lives in Cynthiana, Kentucky, and that she's thankful, luckily that he receives his medication, and he does state the same thing, that he feels like he doesn't have a mental illness. So
good for him.
Well, end that on a positive note, and just want to say welcome to Tracy. Didn't get to see her at the intro.
Thank you.
Yes,
that's interesting. Somebody asked if I'm taking new patients. I am not. I'm on the tail end of my career. I'm semi-retired. I'm doing some things. I'm working some special grant programs. But real quickly, I know we're wrapping up. One of the things important for me today was I'm trying to become a larger political advocate for the mentally ill, and to educate people to stand up and speak up and say, hey, if my loved one or I'm not on a shot, why not? Why am I not on a shot? Hey, can I get on just a shot, no pills? Hey, can I get on that shot that's twice a year? I want people asking questions. I want them speaking up. And I think we can break down those first two barriers. And I have a little wish, and my wish is 25% by 2025. I would like to see 25% of the people in the United States with schizophrenia and bipolar on long-acting injections by 2025. And, you know, we've been stuck at 10% for over a decade. Let's break out of this, folks. I mean, we have what we need. And like I say, the whole thing with COVID, I think, has really helped me think about it in a different way. When we talked about it and we said, hey, take the jab, it's not a big deal. This can make things better for you and for everybody. And I sure hope we did it. I wish we had this for cholesterol problems and blood pressure problems. Could you imagine any medication, any condition they had, they could take an injection twice a year? Who wouldn't go for that, you know? So God bless y'all. Thanks for attending.
Okay, thank you. And we enjoyed your presentation, and I'll get that email, the PowerPoint sent out to everybody who was attending today.
All right, bye-bye now.
Okay, bye-bye.